everyone. My name is Ananda Galapathy, and I'm the one of the co-directors of MHPSS.net. And on behalf of the network and the MHPSS Design Lab team, I'm really delighted to welcome you to the second webinar in our short series, This Much I Know, Practitioners Reflect on Community-Based MHPSS. Now, if you joined our first webinar with Ken Ondoro and Mike Wessels, you'd know that this series consists of conversations with MHPSS specialists about what they have learned from their experiences in implementing community-based approaches to MHPSS. And this series is a part of the MHPSS Design Lab pilot project, which is led by MHPSS.net in collaboration with TPO Nepal, and is supported by UNICEF, GIZ, and the German Federal Ministry for Economic Cooperation and Development, BMZ. And the MHPSS Design Lab is a methodology for building capacity and supporting organizations to co-create community-based MHPSS interventions with crisis-affected people in ways that are tailored to their specific needs and context. And we hope to be sharing more about this approach towards the end of the project in a couple of months' time. Our conversation today will be with Mukasa Moses Wesige, and will be hosted by Rebecca Horn. And before I hand over to Rebecca, please allow me to briefly introduce her to those of you who have not met her yet. Rebecca is an independent psychosocial specialist who has worked as a psychosocial practitioner in humanitarian settings since 2003. Her work has included research, assessments and evaluations, capacity strengthening, coaching, mentoring, and also working directly with organizations to integrate psychosocial approaches into their programs. Her focus is primarily on community-based psychosocial approaches, particularly with populations affected by conflict and displacement. And on a personal note, it's been a special pleasure to be working recently with Rebecca on developing and piloting the MHPSS Design Lab methodology. Rebecca, let me turn the webinar over to you.
Thank you very much, Ananda. It's great to be here, and I've been watching people arrive from the waiting room. It's so good to see you all here, some old friends and new people. So you're very welcome, as Ananda said. And especially welcome, of course, is Mukasa Moses, who we're going to be talking to today, or I'll be talking to. Mukasa and I first met in 2019 through a community-based psychosocial support, or CBPS, capacity strengthening program with the ACT Alliance when I was doing some work with ACT Church of Sweden. And I'm really pleased to have had the opportunity since then to have interacted with him in different forums, and I have learned so much about community-based approaches from talking to Mukasa. So it's great that you're with us today. Very welcome. So currently, Mukasa Moses is the Inter-Regional MHPSS Officer for East and Southern Africa regions at the Jesuit Refugee Service. He's an experienced MHPSS practitioner and researcher with a focus on community-based approaches to mental health and psychosocial well-being in humanitarian settings, particularly with populations affected by conflict and forced displacement. For 10 years now, he's worked with both academic, national and international organizations within the sub-Saharan region in countries such as Uganda, South Sudan, DRC, Zimbabwe, Kenya, and at UNHCR HQ Geneva in Switzerland. So his experience in the mental health and psychosocial field, of course, includes community-based psychosocial support programming, also implementation, assessments, evaluations. He has a special interest in suicide prevention and response, and in the MHPSS gender nexus using an intersectional lens. So we have lots to talk about today. You're very welcome, Mukasa.
Thanks, Rebecca, for having me. Very excited to be here.
Great. You're joining us today, I think, from Juba. Is that right, in South Sudan?
Yes, I'm joining you from Juba, indeed. Yeah.
Fantastic. Great. Well, shall we jump in with a question to begin with? So I'd like to know, to begin with, if you were going to describe community-based MHPSS to somebody you just met on the street, maybe a family member, somebody who has no knowledge of this field at all, how would you do that?
Thank you, Rebecca. That's an interesting question. I will respond to you the same way I recently responded to my grandmother who was asking me what I do in emergency programs. So in my experience, I will describe CBMHPSS as promoting meaningful engagements and collaborative efforts between the external actors with the communities and affected populations to repair and strengthen the social, emotional, and psychological foundations of well-being. And I think it's also very important that such a lay person like my grandmother understands that engagement and participation are the foundations of general community awareness. And understanding that probably will enable that person, like my grandmother, of course, to know that once communities are engaged and they feel they have a sense of control towards their own recovery, then we are doing community-based MHPSS. Yeah.
Thank you. And how did your grandmother respond to this
Yes,
explanation?
Exactly. So it happens that my grandmother is a seasoned psychiatrist. She believes in a clinicalization of mental health. And so she was like, how possible is it that just engaging people promotes their wellness? And I remember replying to her that well-being is multidimensional, and the last phase of the last part of well-being that probably depends on many other dimensions is the mental, the cognitive. So if we work at those other dimensions, the social, the emotional, the systems, the foundations to which well-being is built on organically, then we achieve wellness generally. So my grandmother was interested in understanding it more. We are still discussing the same way we're going to discuss in this webinar.
That's great. And it's interesting you say that your grandmother is a psychiatrist. I didn't know that, but I do know that when we first met, well, even before we met, you started your career as a clinical psychologist, didn't you?
Mm-hmm.
So when we first met, you did have quite a clinical or a medical approach to your work with refugee populations in Uganda at that time. And now you're very much engaged with the community-based approaches. So I'm wondering whether there was any particular experience that convinced you of the value of a community-based MHPSS approach.
Thank you, Rebecca. It's true. That time, I was involved and engaged in multiple emergencies. And I think by the time we met, I was responding to the South Sudan emergency. That is, I think, around 2016, 2017. And for me, as a young practitioner, I thought I was supposed to carry my DSM-5, diagnose everyone, and make sure that everyone receives that diagnosis for their stay in the settlement. And unfortunately, I let alone realize that building natural resilience and recovery within an affected population is not about psychopathologizing everyone. And it's not even possible for us to define their normal responses to what they've gone through as psychopathological, as I thought initially. So the eye-opener for me was after our engagements, I think, with you in that discussion about community-based PSS support. That's when I realized that probably if we appreciate the community and its resources and what they can do for themselves, maybe that could have solved the issues that we are dealing with in emergency. However, I remember mentioning this, I think, to you and some colleagues in the past, that this does not dispute and dismiss the fact that indeed in the same operations, there are people who may need specialized mental health care. But unfortunately, in that emergency, I remember very well, we worked in a way that kind of, even when we try to engage with the CBPS way of working and thinking, we still believe that maybe we needed psychiatrists and psychologists to take lead in caring for those who had specialistic needs. Within the CBPS approach, for me, one thing I tested at that time was probably we can equally mainstream the CBPS way of thinking in the specialized care arrangements, because most of the people who had crossed from South Sudan with pre-existing mental health needs were under the care of their own families than us who they were meeting in Uganda. And it triggered me to think of how can we establish a collaborative care arrangement between us as experts who have learned a lot of theory in universities and the primary caregivers who have been primary carers of this population back in South Sudan. And once we engaged in that direction, we noticed that there was a lot of care for those ones who are receiving specialized mental health support from the psychiatrists and psychologists, but also we were able to but the burden of care from our side was reduced. So the turning point for me was the community recognizing and seeing that natural resilience is easily built when we don't diagnose necessarily, when we don't psychopathologize normal reactions, when we believe and trust communities as experts of their own recovery and experiences.
Beautifully explained, Mikasa. Thank you so much for that. It sounds like quite a powerful experience for you in that work, a real shift in the way that you'd seen what your role was and the role of the community.
Mm-hmm.
I wonder whether there is one example of a community-based MHPSS approach that really stands out to you, that really struck you, that you could tell us about, maybe about the process and something to do with the outcomes. Is there anything that comes to mind?
Thank you, Rebecca. I'll pick one example from the 6 emergencies I've attended to in the last few months. I was in northern Uganda, and you may have heard already some literature that it has, amidst the ongoing complex emergency situation there, Uganda has been ranked as having the most suicide cases literally in the region. Imagine like we are dealing with influx of people, and then we have this declining resiliency, overtaxing resilience situations in the settlements. So one of the things I remember that is memorable from a CBMHPSS way of working that helps us to bring the situation back to normalcy was us going to the community. We had tried all this specialistic way of working. We had classified people as mentally ill. We had done everything you can think about from a public health promotion perspective. We had to go back to the community, dialogued with the community, engage them in understanding what could be the drivers of suicidal behaviors. And the community offered to give us what they were doing back in South Sudan, including how they were providing emotional support, how communities had cultural activities that used to instill hope in those who are at risk of suicide, such as the young population. And once we did this, I remember that we established a community structure called the community-based para-counselors. Up to now, it is still there. It was a layer of resource persons from the depth of the community, speaking the local language, knowing what hope is. They know the idioms of distress in their community and what they used to do before coming to Uganda during the emergency. And they knew how to mobilize resources and connecting activities and pure joy activities that they could use to target the entire population which was at risk. I'll tell you, this was powerful, and it reversed the trend of suicides from 2 deaths per month to literally 1 death in 3 months. So it shows you that, believing in the community and working with the communities, they have a lot of knowledge, resources that we just need to map, trust, and work with. So for me, that is memorable, and I think and believe currently in Uganda operation, it is something that we've documented and believe everyone knows how it has worked to reduce suicides in northern Uganda settlements.
And you say that is still ongoing, that initiative for the para-counselors, yeah?
I left that operation 2 years ago, but up to now, it is still functioning with no incentivization. But because the community feels they have to drive change, care, and support by itself, the structure is still in existence up to date.
That's amazing, isn't it? With no incentivization, that's really encouraging, inspiring, in fact. Did I hear you mention something called a pure joy activity?
Yes.
I love the sound of that. Can you tell us briefly what that is?
Yeah, so having worked in emergencies kind of take away this safety net that brings people together. It takes away all these traditional things that used to make people happy. So in my own language, what I always refer to as pure joy are those things that communities can do by themselves to bring themselves together and find happiness and joy. For example, children, having to come together and play using the traditional play activities they are used to, other than us creating new things or inventing new things. Sometimes the new things don't necessarily bring happiness. The older persons I've worked with in emergencies, they have those traditional ways of feeling happy and connected. So like, for example, them sitting together and they discuss, them passing on their heritage and culture of happiness and joy and hope. Like, these are things which I've seen powerful, and they always remind people to keep happy and to focus to the future. Yeah, so those are what we call pure joy activities that are culturally appropriate and are initiated by the community itself.
It's a beautiful phrase. I love it. And it sounds so simple. And yet, as you described, really powerful, isn't it?
Yeah.
I wanted to ask you, you're talking primarily, I think, about humanitarian settings. And very often, of course, we see community-based MHPSS approaches integrated with other activities like child protection, like livelihood, shelter. And I wondered whether you might want to reflect on that, or be able to reflect on that a little bit, on why you think that is, maybe particularly in emergency settings.
Yeah, thanks, Rebecca, again. MHPSS kind of, there are multiple vulnerabilities that intersect with people's well-being. When you look at, recently I was in RANK. RANK is an emergency program going on currently, receiving Sudanese refugees. I was there last month, and you would see how the child protection risks intersect with the well-being of children. You see the GBV and the need for learning among school-going children is intersecting with how their psychological well-being is, emotional well-being. So MHPSS inherently, if it's integrated within emergency response, helps us to reduce both the short-term risks that increase vulnerability to long-term mental health conditions within the general emergency affected population. Secondly, we cannot keep looking in emergency at well-being of people by only giving them material support. We need to look at well-being. We need to look at well-being in a way that is personologically oriented, like looks at holistic picture of people's well-being and the actions that other colleagues, other sectors can do to promote well-being. We know in emergency that we tend to forget how important it is to speak about MHPSS, and sometimes how hard it is to work with the communities, because everyone wants to rush into life-saving interventions, to use the word. But in most cases, in my experience, I've also seen that it is true that all these sectors can achieve much more if they have MHPSS considerations in their actions and how they are doing their work. For example, knowing that children may require social emotional learning activities, play activities, in transit centers, for example, where I was in RANK, Jesuit Refugee Services was doing this so much, like keeping children away from having to feel bored and reminded of the distressing events back home. So the child protection colleagues thinking of how to integrate these in the work they are doing can be a foundation to promoting long-term well-being of children in the long run. So we need to recognize how MHPSS intersects with the vulnerabilities that other sectors are trying to address within emergency.
Yeah, and what you're saying really reminds me of the conversation with Mike and Ken last week. Was it last week? It feels a long time ago, maybe the week before. And the way that they noted that actually for communities, for individuals, for us, ourselves as people, we don't split things into these sectors, do we? We see things that affect our lives either positively or negatively, but we don't think this is a child protection issue or this is an MHPSS issue. Everything is so interwoven in reality.
Mm-hmm.
And
exactly.
Yeah.
Mm-hmm. Everything we do, I think, in emergency is to promote well-being and build resilience. Unfortunately, I think because there's a classical understanding that in humanitarian response during emergency, we need to separate these things. We need to say everyone do what they can. But if we can actually think of how to promote the CBPS approach in the work that colleagues are doing in emergency, probably we even end up spending less, but also be more intentional in our actions. So I think everything we do, people need to think that everything we do is about well-being, not only, thinking in terms of doing, but thinking of what is the end result of what we are supposed to be doing in our specific sectors.
Great. And often the end result is similar, isn't it? It's about strengthening the well-being of the affected communities. Thank you. I have a question. I'm going to try. I hope I can explain it well. Let me try and see how I do. If it doesn't make sense, then just tell me and I'll try again. So
Okay.
I find that very often people in the field, people use the term community-based MHPSS in different ways. And there's a whole range of different ways that it's used. So it can sometimes, when people talk about it, include interventions that involve the community, but are driven by external actors. And then at the other end of that range, we have approaches where activities are primarily designed and led by members of the community themselves. And I wondered whether that resonates with you, whether you recognize that range of ways in which the community-based MHPSS term is used, firstly. And then the second part to the question is, do you see any particular benefits from the use of approaches that emphasize that the end of it, which is more about community agency, community ownership?
That's a very interesting question, Rebecca, and I'm glad you're asking it at this point. If you go to the field, the deep field, literally every agency you meet, they will say, we are doing community-based MHPSS. We are doing this. But it takes us back to the principles. What are the principles that guide a good community-based MHPSS program? And why should we do MHPSS? One of the things that I've noticed in my experience is a good community-based MHPSS program probably should strongly speak about engagement and participation. And not just participation. We have like agencies coming to just collect information, manipulate, placate, or just inform communities, and then they pick, all this and then say we are doing community-based MHPSS work. But a good MHPSS approach that should really represent an institution, in my opinion, should be one which meaningfully collaborates with communities to co-create solutions and come up with interventions that are community-oriented and are driven by the community itself. I'm not saying that when we say community-based PSS support, we are dismissing the role of external actors. I think it is very important that external actors look at themselves in community-based MHPSS as facilitators of efforts and resources that communities already have. On the second part of your question, if I've really got you well, I think community-led interventions are very powerful, but even they turn out to be more powerful if I'm trying to rethink about, because it's lengthy, it's been a lengthy kind of phrased question, but if I've got you well, a sense of urgency is normally achieved when people feel they are in charge of their own processes and experiences. So the more communities lead interventions, the more they lead initiatives, is the more they feel this sense of community efficacy. So they feel they are in charge of their own well-being. They feel they're in charge of their own communities. Their voices are recognized and are seen as important. And it can even be more impactful when external actors come to only facilitate them to achieve the things they've put in play. And on the other hand, when external actors come with initiatives that they drive in collaboration with the communities, then there's a lot of meaningful impact that can be achieved. Yeah, I don't know if I've really given you the right response that speaks to your question, but I think if in case it's not clear, you can really ask again.
I think you have, Mukasa. I think, what you've reflected on is this balance and the tension, isn't it, between the role of the external organization or supporting agency and the agency or the efficacy, the self-efficacy, community efficacy within the affected population. And I think maybe particularly in emergency settings, sometimes that's tilted a little bit unbalanced, let's say. I wondered whether we're talking very much about the strengths and the positive side of the community-based MHPSS approach, and clearly there are many strengths and it's very powerful. I wondered whether you might have experience of or reflect on whether in some situations there may be downsides, there may even be risks to a community-based or a community-led approach, particularly in the kind of humanitarian settings you've worked in. And I see you smiling, so I'm guessing that means yes.
Yes, I would say yes and no.
Okay.
To start with the yes, it's true that when we give back power to the communities, they drive their own recovery. But it's also very important to recognize that, to give an example of the refugee settlements, people come from their own countries which had already dynamics that we are not aware of. Dynamics in terms of tribes, ethnic differences, pre-flight conflicts, and all those things. I'll give an example of my recent experience in northern Uganda. We had a crash where close to 5 children were murdered in cold blood. And this is how it happened. So sometimes when we misunderstand what community MHPSS is supposed to be done, we tend to think that it's about giving everything to the communities. They drive everything. But you should be able to recognize that the communities that you are dealing with have been ruptured and fragmented. And it's likely that those ones who were vulnerable before the conflict, before displacement, are likely to descend into more vulnerability because they are minority, because they are a weak population, because they are a weak group. So you need to go to the community and know, who are you giving power to drive recovery? Who are you engaging? Is your engagement putting into consideration the human rights and equity principles? Is it putting into consideration the do no harm principles? Are you making sure that those you are giving all the power to drive everything in the community are all inclusive? So sometimes when we allow communities to initiate their own interventions and we don't pay attention to the nitty-gritties of what they can do that can be very dangerous, can disconnect people, it becomes a very dangerous thing to do. On a good note, if we follow the key guiding principles like, human rights and equity, participation, meaningful participation of everyone, and, looking at population not as holistic or homogeneous, but looking at groups as groups which are unique, not referring to everyone as a community, but knowing that communities are unique, they have different needs, and how they should be engaged and how we should engage them to drive their own recovery initiatives should be based on those unique factors that they have as a group, as a population. So it's true, poorly thought about community engagement and participation and giving back power can be very harmful. But well thought community engagement and working with the communities from that angle can be very powerful if it's done rightly, with a lot of thoughts, processes going on, and considerations put into our thinking.
Thank you, Mikasa, for that really thoughtful response, and also reminding us that we do have guidance, we do have things that we can draw on to help us to ensure that we do no harm in these really difficult situations. I think, soon I would very much like to I think we've got some good questions from our colleagues who have joined us, but I want to take advantage of my position to ask one final question, if that's okay, before we do that. And it's a kind of a big question, but let's see how this goes. In your experience, Mikasa, what have been some of the key factors that make a community-based MHPSS really work? And what are some of the factors, what have been some of the factors that you've seen that have derailed or limited the effectiveness of this type of approach?
It's a nice question, Rebecca. I'll give you two answers. One, engagement and participation are the foundations of a successful community-based MHPSS program. And not just, I've just said this earlier, it's not just participation, because participation is, in humanitarian work, we always look at participation as coming and collect information. It's not about consultations. It's not just about, coming and you ask communities questions and then you go. We are talking about meaningful engagement and meaningful participation. It's about collaboration with the communities. And once you have this, you never go wrong. It means you're able to design programs that are meaningful to the community. It means even if your programs come to an end, even if an emergency program goes to the development phase itself, these will be sustained because they speak to the heart and feelings of their communities. And what can derail it much more is when we think we are the experts of what communities need. So that is one of, if you want it to fail completely and you spend a lot of money, just become the expert of what happens in the community. You successfully fail. Yeah.
I love the idea of
Yeah.
successfully failing.
Yeah.
Thank you for that. Thank you so much for these really thoughtful and thought-provoking things that you're raising, and I think they are provoking some thoughts amongst the other people who've joined us today. Ananda, can I ask, are there some questions that we could bring?
Yes. Hi. Yes, we do have questions, and I'd like to invite colleagues to post more in the chat. So we have a question that sort of follows on from what you were just talking about, Mukasa. Leslie was really appreciating the way in which, hearing about the ways in which we can engage communities from their own cultural practices and knowledge, and was asking about, what as practitioners we really need to be especially aware of in working in truly participatory ways in MHPSS. Perhaps if I expand on her question, what are the key things that we may need to be aware of, but also what are the key capacities that we need to cultivate in ourselves in order to, and perhaps our institutions to be able to do so?
Should I take it, Rebecca?
Yes, you go ahead, Mukasa. Thank you. It's a really great question. Thank you, Leslie.
Thank you, Leslie. Things to be aware of: communities are not homogeneous, because sometimes when you go to work in communities, we look at refugees as a refugee community, and then we engage them as a community. So we need to understand that refugee affected populations are unique, and within that larger, bigger community, there are communities within communities. And as such, if we are to map resources that are important for their recovery and resilience building, we need to collect resources that are defined by or within a specific community: language, culture, traditional practices, religious practices. So, things that they are aware of, they carried from their countries of origin. So we should kind of, as institutions, be aware that once we define them as one group of people, we are losing out on collecting information and resources that are important to building long-term resilience for such groups of people and communities. Thank you, Leslie.
Yeah, I'd like to come in if I can. I was interested, Leslie, in the part of the question. I think it was something about what qualities do we need? And I feel like that is sometimes where we fall down, in that the qualities we need, as Mike explained has explained so clearly in his writing and also in webinars and other things. Humility is one thing, and often we lack that humility, as you were saying, Mukasa, when we come in as the experts. But also, I think it can be quite scary to feel like we don't have control when we are working for an organization and we know that we're expected to perhaps deliver certain things or produce certain things or have to report on certain things. And to really give up that control means that we don't know what will the outcomes be. We don't know what the decisions the community will make about what they want. What if it goes against our humanitarian principles? How do we manage those difficult conversations? What if they ask for things that we can't give? How do we manage that? We might make them more angry, and we perhaps don't feel always that we have the skills to engage in these long, slow conversations. And it's so much about relationships, isn't it? And in emergencies especially, I don't know what you think about this, Mukasa, but in emergencies especially, there's such a rush, there's such a rush to get things done. And the community-based approach is about building relationships. It's about listening and taking time and having discussions, going away and coming back. And I think that can be something that is difficult when we are under time pressure, but can also be difficult in terms of our own confidence to go through that process and really listen and give up some of the control that we often have as employees or as staff in humanitarian organizations.
If I could just jump in with a question from the chat, but also one that was one that came up in the last webinar with Ken and Mike. Just picking up on what you were saying, Rebecca, about that the sense that there isn't time for engagement, that there isn't time for consultation, and Glaucia has been asking in the chat, how can we ensure that affected communities are involved in the design of MHPSS activities when there is insufficient time in project design for needs assessment or community consultation? And I think this is particularly true, this sense that there isn't time in the context of humanitarian responses. Could you speak a bit to that and how you manage to engage in such context, which is what you've been talking about so far this evening?
Yeah, go ahead, Mukasa. You're doing this right now, aren't you, in relation to the Sudan situation? So yeah, please.
Yeah, thank you, Rebecca, and thank you, Ananda. I think the most important part for me, like from what I've observed in the last 1 month in rank specifically, is to trust. I know we are always very worried and fearful of what can come out of us giving everything to the community, but we need to trust the processes that communities, we just need to trust communities. As I mentioned, they know exactly what they need. And then secondly, we need to learn to listen to communities. And listening gives a strong foundation to relationship building. Normally in emergencies, I remember I was in one operation, not to mention here, because people will be spotlighted, when many people came with shirts labeled psychologists, mental health practitioners, and all that. And you literally communicating how domineering you are to the population you're serving. You need to learn, people need to learn in emergency to listen to communities. You need to listen to these voices. And once people feel they are listened to, and I think this is the background to PFA, to remind us to be more open to listen empathetically to communities. And as people transit over time from emergency, we are already there with them. They feel like we can imagine their experiences. It's more of us learning to be humble enough from the high level qualifications to listening to these people and being available. I will tell you, in rank, it's been very chaotic with people fighting. This is Sudan, people fighting within the center. But what we've been telling humanitarian actors in this operation is, can we be humble enough to go and listen to communities? They start to trust us because they will think we are there. We understand what they are going through. So for me, the point is trust and being humble enough to listen to communities when they speak to us. These are the foundations of good relationship building in emergency.
And can I just ask Mukasa, is there time? Is there time for that in rank?
There is always time, Rebecca. Absence of time is within the, humanitarian workers, we like rushing everything. We are saving lives, but I'll tell you, Rebecca, there's always time to sit down with a person who is affected. Even before you take them to the next shelter, I think it's good humanitarian practice to listen to people and give them chance to speak to you and you listen to them. There's always time, Rebecca. I've seen it in rank as people are crossing with gunshot wounds and we are taking them from the border point to the transit center. As they reach, they are all tired and we have chance to communicate to them. We have chance to hear what they have to say if they want to speak about it. So there's always time, Rebecca. And I always crack this joke with the technical colleagues, the WASH colleagues, to use the word. I'm sorry for the WASH colleagues who are here. They think it's always about them, not the community. We have to put water here. But how about if communities do not need water at that specific point in time? Maybe they want it somewhere else. So it's more of desiring. We need to have the desire to listen. Even if we are in a rush, we must listen to the communities and we must trust them. There's always time, Rebecca.
That's a beautiful answer. Thank you so much. Ananda, more questions?
Yes, we have many more questions. So, and we've got also comments in the chat, which I'm not going to relay simply because we've got 15 minutes left, and I'd like to put to you as many questions as we can. So there's a question from Grace, and which echoes also another from Ismail. Grace asks, who would be the key people within the community to involve in terms of providing MHPSS? And Ismail also asks about the role of leaders, of community members and their own perceptions of mental health conditions or religious practices, and how those also intersect with community-based MHPSS approaches.
So one of the things I've done over time in practice has been to use what you call the community-based asset mapping tools. So normally when I look at a community, I look at it, as I mentioned, that well-being to Moses, to Mukasa, is not well-being to Rebecca. So well-being is defined by so many things, and who promotes that well-being is who I identify with, my age, my culture, my gender, my sexual orientation. So the religious actors are part of the majority, the many resources that we can collect from the communities. In fact, it's in good practice if you want to get more resources from the community, which can help you promote well-being, to use to think about what we call community-based asset mapping tools. You go to the communities, do not look at a community as homogeneous, as I mentioned earlier. So you identify who can promote well-being from a group that is already defined. If it's children, peer-to-peer, promote well-being within children and youth. If it's older persons, putting them in a group as older people to speak about things that they know themselves promote well-being can be powerful. It's also true, as Ismail mentioned, that religious figures are gatekeepers of the entire community. So engaging with them can help us address issues like stigma, which have a direct linkage to general community wellness, protecting those who are at risk of seclusion, because we can work with religious actors to speak against stigmatization of such populations. So, but at the end of the day, we need to go back to tone it down and look at who in a specific population, culture group, religious sect can help us, can work as a resource that we can build on to promote well-being for that specific group of people. Yeah.
Thank you, Mukasa. I don't feel the need to add to that. I think let's go to another question, because this is so interesting, and I think we've got a lot more, haven't we, Ananda?
Yes, we do. So Katerina is asking a slightly different sort of question, asking what kinds of approaches in your experience are most effective in advocating with your own staff, and especially at the management level, on how important or significant it is to ask communities what they need and not to assume that we know this already. So what works in terms of internal advocacy for more community-oriented and community-led approaches?
I'll give my opinion, and I'm disclaiming this is my opinion. Sometimes managers, high-level managers in institutions do not have a clear appreciation of how important it probably is to engage communities. So I would think mainstreaming MHPSS, community-based MHPSS principles literally from institutional management to the grassroots frontline staff is very important. So one of the things I would recommend for me, in my opinion, I think, Rebecca, we've done this before within the ACT Alliance, that managers and institutions need to be oriented on community-based engagement and how it is important in proper programming. Secondly, mainstreaming does not only mean that we are going to train people and then we go away. It equally means we need to institutionalize this way of thinking. We need to make sure it's part and parcel of our culture of operation. We start to challenge those projects developed at high level that are developed on our desks and imaginations, to pushing back, to taking us back to the basics of what are the basic principles of humanitarian response? What defines humanitarian institutions? We need to go back to the core humanitarian standards. So actually, absence of community engagement contradicts the heart and the core principles of our existence as institutions. So we need to take back and remind managers that our work is defined by those traditionally developed and agreed upon principles by the IS guidelines.
And maybe I could just add one little thing. Can I? Yeah, so with my work with Act Church of Sweden and the ACT Alliance, a lot of it was about working with organizations who didn't have a background in MHPSS to help them to integrate community-based approaches. And really in terms of advocacy, once we, as Mukasa said, once we oriented the managers to what it is, what CB MHPSS is, they very often responded by saying, but this is just good practice. This is good practice in WASH. It's good practice in shelter to do all of these things. And I think often they just have a misunderstanding about what's involved. So one thing, as you've said, Mukasa, is to clarify that things like participation and so on, these are good practice. And secondly, they will make you more likely to achieve the goals of your particular project. Even if you're not interested in the overall well-being of the population, you are more likely to achieve your goals in shelter or in WASH or whatever the sector is, livelihoods, if you do integrate a community-based MHPSS approach. Thanks, Ananda.
Thanks both for those responses. I'd like to add a question. It's not actually in the chat, but it's one that I've been hearing recently in a number of forums, including spaces where field practitioners are grappling with how to do community-based MHPSS. And the question is this, is that you're right, if you look at the guidance around how one should respond, many of these practices of engagement, of consultation, of population-led decision-making are there. However, the reality sometimes of how the institutional processes, grant mechanisms, funding deadlines, needing to define deliverables ahead of ever getting resources to go to the field. Some of these parts of the kind of the infrastructure and the way in which humanitarian and development work operates nowadays seems to be very difficult to overcome. It's very, and the practitioners who were speaking really talked about how they struggled to find ways to be more community-led in that context. Is there any advice or any tips that you might be able to give them on how to work with essentially very top-down structures for funding and program design?
This is certainly for you, Mukasa.
Yeah, thank you. I'll give you my opinion still. One of the things I've learned over time for sure is it's true, Ananda, that institutions normally focus on what they can do at a very fast rate. Humanitarian institutions are always on a rush. We are always in a rush on everything. But I would quite tell you that we need to think of what added value, even to donor communities. What added value can we cultivate by working both from a bottom up, using the bottom up kind of thinking to versus working at a high level, top down kind of approach. So we need to engage donors, first of all, because sometimes institutions are victims of their donor needs. So we need to involve donors in this discussion and probably have them understand that developing a relevant project that will intentionally and intentionally solve or challenge or help communities overcome their problems should come from the voices of the community itself. So I think for me, it's more of us to doing advocacy at all layers, donor level, engaging donors to start to speak this same language. Because sometimes institutions end up jumping this very important area of community engagement and giving power to communities because donors require us to submit things on time. It also requires to submit things as they wish them to be submitted. So one recommendation is can we engage our donors in roundtable discussions to know exactly what we are saying? Secondly, can we take a step to pause and reflect on how it can be beneficial to our own programs if we work with communities? If we first consider going to the communities, collect most important information from them, get their inputs and recommendations, and then we define this as a proposal, rather than us sitting up there and thinking for people who we don't even know. We don't even know their values. We don't even know what they cherish. We don't even know what is their heritage. How do they define well-being? What are the idioms that they use to define what good mental health is anyway? So it's more of both engaging at high level, at middle level, who are us, the recipients of grants, and also going back to the communities, because we've spoiled communities already. Communities are already spoiled. They believe we are supposed to give them. They don't have power. So we also need to go back to the communities and enable them to know that it is their right to participate in program development processes. Thank you.
Rebecca, would you like to add to that?
I think I haven't got anything to add to that. That was fantastic, Mukasa. Thank you.
Thank you very much.
Very powerfully expressed.
We just have a few minutes more, so maybe one or maybe two questions if we're lucky. So there's a question, a really good question from Joshua. And I think this is for those of us who may be interested in implementing community-based approaches but have not. Is there a structure or framework that guides the implementers of community-based MHPSS? And how, and I guess what kind of supervision or support is required for people who are starting to do this kind of work? Perhaps both of you could respond to that. Thank you.
Okay. Rebecca has a lot of experience with this, but I'll give my opinion still. I think like when we start to speak the community-based MHPSS language, it means we are trying to institutionalize this. For those who don't have the capacity, we need maybe to start by building the capacity within staff themselves. Then secondly is when we talk about a framework, and Rebecca, you can correct me, is CBPS itself or CB MHPSS is not an activity to say, it is a way of thinking, it's a way of doing things. And in that sense, it is guided by some good core principles. And once staff are able to be oriented or to understand how we can integrate these principles in the work we are doing, it becomes actually more basic and more easier to do. I'll tell you in my experience, the easiest approach to integrate and mainstream an organization is community-based MHPSS. So the framework, the framework to guide you are the core principles. And then the second thing we can do is for us to build the capacity so that everyone gets to appreciate what it is and what it is not. Yeah, over to you, Rebecca.
Thank you. Yes, it kind of goes back to the question earlier of what we mean by community-based MHPSS, isn't it? And sometimes it's described, or the term is used in different ways. The real community-based MHPSS is I don't know of any training or anything like this that is really able to communicate that or give people opportunities to practice that. And I think what we're trying to do with the MHPSS Design Lab is exactly that, isn't it, Anne? And what it involves is the framework, it's the guide, it's the core principles, it's the I mean, there's lots of things around that we can read and we can draw on in terms of community-based MHPSS. But as you've explained, Mukasa, it's different in every context, it's different in every place. And so it's only by doing it and learning what's working, what's not working, trying again, trying differently, talking to people, that we can build up those muscles or those skills that will enable us to keep doing that in different contexts and learning again and learning again. And it's always about learning again. The other thing I would just mention, I know we're really short of time now, is to go back to the point you made, Mukasa, earlier of needing to work at different levels. We if we're working with organizations, then we really need to get the buy-in from the managers, from the senior managers to this approach. And my experience is that's the thing that's really hard. The people who work in the field are, as you said, Mukasa, so they're already doing it very often and they want to be doing more of it and be doing it better. But they're not able to, because it's the managers who are not understanding the approach and what's required and what's involved and how to do that in their context. So yeah, it's really through a little bit of input and then practice, input, practice, input, practice. And that's what we were doing, Mukasa, isn't it, with the CBPS strengthening project that we first met on with the ACT Alliance. It's a bit of a rambling response from me, sorry. But yes, I think I'll stop there.
Thank you both. I'm afraid that we will all have to stop here now because we're out of time. But the good news is that this series is going to continue. And from the nature of the conversation we've had so far, we've still got so much to talk about. And I'm really, really grateful to both of you, Mukasa and Rebecca, for this very wonderful, warm, nuanced, and profound conversation about CB MHPSS practice. I really enjoyed it, and I think everyone else in the chat is also echoing this. And you left us with some really great sound bites, but also really memorable examples from practice, like I think in the very first bit about the pure joy activities and the power of community-based approaches just to impact really serious issues like suicide rates in the context of acute displacement situation. So thank you so much. I would like to invite everyone, if you could, to take our 4-question poll, which Valeria is just going to put up on the screen right now. Just 4 questions, multiple choice, takes no time at all. We will be in touch with you all with the details of our next webinar in the series. So please stay tuned for that. If you signed up for this one, we'll put you on the mailing list for the next one. We'll also be sharing this via our social media and on the MHPSS.net website. To follow MHPSS Design Lab on Twitter, which is where it's at right now. And you can also join the community of practice on MHPSS.net that is dedicated to community-based MHPSS. Once again, thank you to you all for joining us, for the great engagement, the great questions, and once again to Mukasa and Rebecca for this really thoughtful and stimulating conversation. Thank you.